Excellent. Okay, well, we're going to now hand it over to Sarah. So everyone kind of just stretch for a moment if you need to get up for 5 seconds. And then while Sarah is going to take it over, get her screen shared and such if you need to take a short break. And then Sarah is going to be talking about our most recent data we collected for Project Better, which is our ongoing it will be a randomized controlled trial, like Deshonda was saying. But right now, Sarah's going to be presenting some of our pre-testing data from this larger study that we've been working on towards for quite a long time. So we're so excited. And this is Sarah's second presentation with us. And so she gave her presentation a few months ago, kind of as we were in the more conceptualization stage of the project. And now she has data, but we have not yet written this data up for publication. So this is the stage where if people do have feedback on how the data is being presented or any of the specific findings, we are going to welcome that feedback because we're in the process of getting all the data analyzed and written up, and we're going to be submitting it for publication very soon. So we really appreciate everyone's input because we've been looking at this for so long, the study team, we start to see the same thing over and over again. Sometimes it's hard for us to see it through a different lens. So Sarah, I will let you take it away.
Okay, great. Thank you, Dr. Martin. Can you see my screen and hear me okay?
Yes.
Okay, awesome. Well, my name is Sarah. I'm a second-year medical student. I've been working with the Project Better team since about last January, and I'm excited to get to share some of our data with you. Like Dr. Martin said, we just finished up our pre-testing literally last week, so this is hot off the press. Let's see. So just for a little outline, first we'll go through some background, go back over the intervention just to make sure everyone's on the same page in case you didn't get to see the presentation in June. And then we'll also go through some of the frameworks that help to inform some of our study tools. And then we'll get into our preliminary results, focusing mainly on acceptability and feasibility. And then we'll go through some lessons learned and our conclusions and how we're going to apply those lessons in the upcoming RCT. So for a little bit of background, everyone knows that pregnancy is a really critical time for women with opioid use disorder, and especially the postpartum period is a really challenging time for all women due to hormonal changes, coming home with a new baby, and then those stressors are really just compounded for women with opioid use disorder who are also trying to focus on their recovery as well as their postpartum transition. So in the preliminary data for this project, we basically asked women in recovery, what are the aspects of the postpartum transition that are challenging to recovery? And the three major themes that were kind of elicited from those conversations were that mothers reported feeling really underprepared to just cope with all of the aspects of the postpartum transition. They were also underprepared to care for infants who might be showing some withdrawal syndromes or have a diagnosis of NOWS. And then finally, they felt underprepared for interactions with child welfare. So even though this, postpartum transition and the increased risk of overdose that is carried during this time has been pretty well documented, there haven't been any other educational interventions for this population group in the literature so far. So in response to this documented need by our patients right here at Motivate, Project Better was born in order to help prepare pregnant women for some of those challenges that they might face during the postpartum transition. So the intervention consists of 3 technology-based modules whose topics include the postpartum transition, NOWS, and interactions with child welfare. And the modules are hosted on a platform called CIAS, or Computerized Intervention Authoring System. And this is a system that's been used for quite some time, primarily in motivational interventions and computerized screening and brief intervention research. But I believe we're the first group to use it primarily as an educational intervention, which is pretty exciting. And so the modules are narrated by this character right here, Petey the parrot. And he kind of serves as this like non-human, non-judgmental animated character who can provide all of the educational material in an objective way, and not create as much judgment as maybe having to sit down with another person. And so the modules also feature interactive activities and questions, like you can see here on the right, as well as the opportunity to select topics that you might want to further discuss with your provider later. The modules also include videos that were made here at VCU featuring providers from all across the spectrum of care, as well as personal testimony and experiences of patients who were able to share those. And so now we're all kind of up to speed on what these technology-based modules actually are. I just want to talk a little bit about some of the frameworks that we use to develop our measurement tools. So first, in intervention research, it's kind of become widely accepted that we really needed to be measuring acceptability, but there was no consensus for how to define or to assess acceptability. Often researchers use proxies like satisfaction or behavioral measures like retention. But Dr. Sekon and her colleagues kind of established that this is a problem and we need to come up with a way to systematically define acceptability and be able to measure it in intervention research. So based on systematic review of the health and psychology literature and also theories and frameworks from health psychology and behavior change, they developed this theoretical framework of acceptability, which includes these 7 component constructs, and can be used to measure acceptability prospectively, concurrently, or retrospectively. And based on these 7 component constructs, we developed a questionnaire that's designed specifically for technology-based interventions that will retrospectively measure acceptability. And then the second thing that we wanted to measure is the feasibility of completing both our larger trial as well as implementing our intervention clinically. And so there's lots of reasons why we should complete feasibility or pilot studies. And so this typology was developed originally for drug trials and then later applied to occupational therapy research in order to kind of group those reasons into succinct categories. And so the creators of this typology determined that pilot studies can and should assess both, first, the processes necessary to complete the main trial, the required resources, human and data management aspects, and then finally how robust the elements of the RCT are scientifically. Okay, and so now we can get into our results a little bit. First, for some just descriptors of our study population, we had a total of 12 participants complete the modules. They were middle-aged and primarily white and with a high school education. We had 8 postpartum participants and 4 pregnant participants. And we'll talk a little bit later about some of the challenges we had with recruiting pregnant patients specifically. Most of our participants had been on medications for opioid use disorder for over 2 years and were primarily on buprenorphine. So for our acceptability data, I'll start by going through our survey questions, which are grouped according to the component of the theoretical framework of acceptability that they're supposed to capture. So beginning with affective attitude, which is how one feels about the intervention. And I would just add that, like, historically, this is pretty much where we stopped when it came to assessing acceptability. So kind of like, you know, how much did you like using the module? How much did you find it to be interesting? So this is usually where people would stop with acceptability. But all in all, our participants scored or like felt pretty good about the intervention. This question about how, to what extent did you find the module to be annoying? We'll talk about that a little bit later, but basically, I think this question just kind of got pulled in as it was historically used to assess other CIAS interventions, but may not have been very applicable to our intervention. So that might be something we have to consider for the trial. Oh, I'm sorry. And I totally mentioned the wrong one. It was this humorous question that we're more concerned about. Okay, so the next questions, we really wanted to assess burden because our participants in particular at Motivate have a lot going on in their lives. So we really wanted to make sure that too much effort or time wasn't required because that would be a major barrier to both recruitment and getting people to be able to complete the study. But all in all, people rated the burden questions appropriately or what we were hoping for. Next, we have ethicality, which is the extent to which the intervention has a good fit with one's value system. And all in all, participants rated these questions very highly as well. We also used this as an opportunity to assess stigma because this is substance use research. So this was a really good opportunity to be able to assess how much the participants may have felt stigmatized by the intervention. And again, they felt like it understood who they were, made for their community, and they didn't feel like the intervention reinforced stereotypes about substance use disorder. Participants felt like they understood how the module was supposed to work and found the content to be understandable. And they also felt that the time spent completing the module was worth it for the information that they gained. Participants also rated the modules as being effective for their health and well-being and thought that other moms in treatment would be helped by the module. And then for our last component of the framework, participants found the modules to be easy to use and were confident that they were able to complete all the modules in the way that they were supposed to. Lastly, these questions don't actually correspond to one of the components of the framework, but these were just things that we really wanted to be able to capture during pre-testing. And one that I'll point out here, because this was a major theme from our qualitative interviews that we completed, participants really pointed out that they felt even more comfortable learning from the module than they did from their providers. They made a lot of comments about the fact that even though they know their providers have their best interests in mind, they still can feel like substance use, especially during pregnancy, can be a really embarrassing topic. And even if their providers don't act like it, they still feel worried that they might be being judged. So they really appreciated being able to learn from this kind of objective parent who has, no judgment to give. Okay, and then moving into the feasibility data, first we have a process assessment. Of the 62 eligible participants, we were able to get in contact with 26 of them. Of those 26, 19 consented to participate in the study, giving us a recruitment rate of 73%. And then 16 of those who were consented were assigned to the module. And of those 16, 12 or 75% completed both the module and the questionnaire. And then those who completed the module and the questionnaire were invited to participate in a qualitative interview, and 75% of those did. Okay, so 92% of the participants demonstrated that they thoroughly reviewed the modules. We did have one participant who during the qualitative interview admitted that they weren't really completing the module and just kind of clicked through. But based on the other interviews, we were able to determine that all of the other participants did review the modules. So this individual's data was included in the demographics, but it was omitted from the acceptability data because it was invalid at that point. 92% of participants completed the module remotely. They were given the option to complete it in clinic or at home, and most all of them did it at home. However, the one person who did complete the module in person was able to finish in the clinical space. So moving on to resources assessment, the two major problems that we kind of encountered, which were expected, had to do with time and technology. So we were asking quite a bit of participants, having them complete a module, which could take upwards of 20 minutes, and then, a survey followed by an interview. So getting participants to be able to finish all of those aspects of the study within a reasonable time period was pretty challenging. And then being able to recruit the desired number of participants within a reasonable time period turned out to be a challenge as well. So we'll be employing some additional ways to increase recruitment during the RCT, which we can talk about at the end as well. We also had several issues with technology, not too many considering that we were, doing REDCap and CIAS, but some participants did say that they were kicked out of the module and had to start over several times, and there was no way for them to go back to, where they had left off, and so they had to listen to the beginning over again. And then we had one participant who was asked to log in to CIAS and didn't know how to do that. In terms of management assessment, which would cover human and data management problems, participants were recruited on, I believe, 33 clinic days, and eligible participants were missed in clinic on only 3 occasions. So we did a pretty good job of making sure that eligible participants were approached for participation in the study. Initially, we missed demographic and acceptability data in REDCap for the first participant, but we instituted data checks in order to prevent that from happening, and we're able to make all of the questions required on the survey so that no one would miss any questions, but they could select prefer not to answer if they weren't comfortable answering one of the questions. We didn't have any protocol deviations and no data management issues between REDCap and CIAS. And so for the scientific assessment, we really wanted to focus on burdensomeness and duration for the modules because these are the 2 areas that we thought might cause problems during the RCT if we were having trouble with getting participants to be able to complete the study. But based on our qualitative interviews, overall participants were very positive about how much effort they had to put in to use the technology and how easy it was to use. They also said that it wasn't as lengthy as they thought it might be, and they thought that it would be really reasonable to be able to complete 3 modules over the course of pregnancy. And then we also wanted to assess our assessments, like the acceptability questionnaire. So in particular, the question about humor, participants kind of were a little bit confused about that question because they didn't think it was meant to be funny. So we will be assessing the acceptability questionnaire further by running statistical tests to see if the questions group together within each category and seeing which questions we need to throw out before moving on to the RCT. Okay, so in general, the modules were rated as highly acceptable to participants. All of the survey items that we grouped under intervention coherence, opportunity costs, perceived effectiveness, and self-efficacy scored high, and the items under burden scored low. And then the methods that we used are feasible and predict success in the RCT. And together, these findings justify further evaluation of the modules for their effectiveness in a clinical setting. And then to go through some of the lessons learned from this pre-testing experience, we found that kind of the major hang-up point for a lot of participants was in completing the qualitative interview, because that was something that had to be scheduled later, and a lot of participants were really busy. So we're not going to do a qualitative interview during the RCT, just to hopefully encourage participants to be more likely to want to complete all aspects of the study. Additionally, one of the inclusion criteria for this pre-testing study was that participants already had to be a part of the research registry. And that added an unexpected challenge because a lot of the pregnant patients are just coming to Motivate and aren't enrolled in the registry. So in order to be recruited for Project Better, they had to be first added to the registry. So that made it really difficult for us to recruit as many pregnant patients. So for the RCT, we won't be recruiting from the registry. We also found out after the fact that there was no standardized way for us to confirm that the participants had reviewed the assigned material because it turned out not to be able to be easily accessed through CIAS how much time the participants spent with the modules. And then our timestamps in REDCap aren't terribly reliable depending on if people went in and out of the modules or if they completed it all in one sitting. So for the RCT, we're going to instead implement some kind of like knowledge checks in order to confirm that the participants were actually paying attention to the material that they were assigned. And then finally, we'll be making revisions to the acceptability questionnaire based on statistics and the patient feedback. And so those are my sources. Thank you all, and I would appreciate any feedback.
Thank you so much, Sarah. It's so exciting to see the data. You did an excellent job synthesizing it together, both our successes and our lessons learned in such a positive sense. I love it. So I would open it up if anyone has any feedback or clarifying questions, because those would be good things for us to know, like, oh, maybe we should explain this in a different way or present this in a certain way as we're writing up the findings at this time. So any feedback, comments, or questions would be appreciated by the audience.
Thank you for your presentation, Sarah. You said that you're not going to be getting the participants from the registry. So what are going to be the changes for recruitment?
So for the pilot test, it was just a criteria. They had to already be part of the registry. My understanding is that for the RCT, we can approach any patient in clinic and they don't necessarily have to already be enrolled in the registry. But correct me if I'm wrong, and Annabeth.
Okay, all right, thank you.
That is correct. The registry is turning out to be a great source for postpartum and parenting patients, but not for the pregnant patients. And this upcoming trial will only be recruiting pregnant patients.
I had a question about, Sarah, great job, by the way. You mentioned that the parrot, because the participants were listening to the parrot, they didn't feel judged at all. Was this, was there like evidence from other articles? I don't know, like how did you guys think to use that as opposed to, I guess, using, I don't know, someone, I guess, videoing somebody? Like, how did you all end up figuring out maybe we can use a parrot as opposed to a human being? Because you mentioned that they felt less judged, and I don't know if that was even something that you guys thought about while designing the study. I don't know if it's not really a question, it's kind of a clarification.
So CIS has been used for actually quite a long time, as I understand. I think Dr. Svickas said maybe up to 20 years. And I think that's been one of the really great successes of the program. And when Dr. Svickas told us that the participants really love the parrot, I was a little skeptical at first, but they it really does make sense. And so I think that's been pretty widely reported in the papers. Maybe she can speak a little bit more to that.
Yeah, let me jump in to say the parrot was not the plan in the research grant that was originally funded for Dr. Steve Andersma, who's the primary person in this work. He had gotten a K Award, his first grant, and it was 20 years ago, literally, to design a computer-based delivery of motivational interviewing. And the plan was we were going to have human figures, and we were going to match to the race of the participant, et cetera, and the grant was behind schedule. And the human figures cost money, and to get started and try out the software, this parrot was free. And so Steve started to use the parrot for the initial pilot testing, and the women loved it. Like, absolutely, that was like the highest rated piece to this. And so after the fact, there's been a fair amount of research now coming out, and it really does look like an avatar provides the opportunity for, just like Sarah said, to not have that response set that you might have with even a really good provider, right? That there's just still this, need to try to say what you think they want to hear. Whereas with the parrot, it sort of takes it out of that realm and lets the person just sort of think about things without censoring, I guess.
Thank you.
Parrot has a name. His name is Petey, if you're in. Petey the parrot.
But it really is, we've used PD in clinical trials, and participants will come in, and sometimes at follow-up visits, they really will speak as if PD exists, to say, like, I can't wait to talk to PD again to do their follow-up assessments. So it's a great tool.
Any other feedback or questions people have? There was one question in the chat that we answered about the interviews that were done, and they were very short. This was not intended as a qualitative study. It was intended more as kind of like a mixed methods, but with the qualitative component being the secondary component to complement the quantitative data that we got from the acceptability surveys that Sarah had worked on. So they were very short, but I don't remember, Sarah, how many participants actually completed the interviews?
It was 9 out of the 12 who were invited to complete it.
So yeah, we did run into some challenges in getting the people to complete them, but they were all done virtually over Zoom, the people who did complete them, which we've done once before for another qualitative study in the same patient population. Any other questions, clarifications, curiosities that people have for Sarah?
I have a question for Steph Violante, but I can ask that after if other people have questions. I have a stats question.
I have a quick interview question that you guys were mentioning. So was the interview used to verify if the participants actually learned from the study, or what was the interview like? What was the purpose of the interview, basically?
So the purpose wasn't originally to, determine if they had actually completed the educational material, but it did kind of work out that way, especially for the participant who it turned out they didn't really review it. Originally, I think it was just to get more qualitative data to, as an adjunct to the survey data, just because it's a little bit more descriptive and we could use it in order to make any adjustments about things that people either really liked or really didn't like before moving on to the RCT.
That makes sense. Thank you.
I don't know if you mentioned this, Sarah. I just wanted to know, as far as the outcome, because really the purpose of the study, I think, was to figure out if, I guess you were able to determine the ways in which women were not prepared once they had their children, the women at Motivate. So as far as the outcome, what do you think now, having that educational piece, they seem a bit prepared? Is that something that you might have mentioned this in your conclusions, but I wasn't paying attention?
I think that's something that will take a little bit more time and research to actually be able to establish. I think that's the hope, of course. But in the RCT, I think there will be an effectiveness measure as a secondary outcome. So hopefully we can at least get some data on that, because one of the acceptability questions did address like perceived effectiveness, but that's not really the same as like a behavior change or some other outcome that you could measure.
Thanks.
Yeah, we hypothesize that, of course we want to think big and that we're going to change the world, right? So we hypothesize that if all women with opioid use disorder who are in treatment during pregnancy got this intervention and completed it in addition to, their routine or comprehensive care, that we would hope that it would equip them with confidence and empower them throughout the postpartum transition to be able to use their resources and kind of know what's going to happen and be able to have that confidence in that parenting efficacy and self-efficacy during a vulnerable period, such as the transition to postpartum. And that would manifest itself, right? We would hope in, improved outcomes on, patient-reported outcomes like those, and maybe reduce substance use recurrence, maybe increase BUP continuity, all those. However, to measure that and would require quite a large sample size. So that's for another day. But for this initial RCT, we need to first prove to other providers in the clinical world that this is not a crazy thing and it can get done, right? And it is feasible. It doesn't hold up your clinic. Patients do like it. They won't see it as this crazy thing. So it is worth the extra little bit you would have to do to implement this into your clinical flow. So we first need to convince people that it's worth doing, just period, just it's able to be done. And then we're going to focus in a future grant, hopefully, on more clinical outcomes.
Okay, I'm going to jump in and ask my question. So Steph, we're obviously not validating this measure because it's such a small sample size, but we want to, because Sarah did a lot of research to get the questions, and then we also just kind of made some up and just kind of assigned them to these categories as best that we could. So I was wondering if calculating like a Chromebox Alpha with 12 people, if that's helpful at all, or if we should just go based on like participant feedback to kind of narrow down our questions and see how well they fit into those categories.
That is a great question. I actually don't know the answer to that off the top of my head about sample size needed for Chromebox Alpha. I mean, I'm always a proponent of it. I think that would be the perfect analysis to do for this measure, but I can look it up for you, but I would have to Google it, which is probably what you would do too.
Yeah, I can do that. I was just wondering from your expertise of measurement development, because it's kind of like the very first stage of expert review a little bit and kind of throwing out questions before.
Yeah, that is definitely the first thing I would do is the Chromebox Alpha. I don't know off the top of my head about the sample size.
Okay, that sounds good. Mm-hmm. Thank you.
12 can be enough sometimes. So we just don't know because it is a small number. Okay, well, we are at time. So thank you guys all so much for coming. And Sarah, amazing job. And thank you.